Ready?
Yep. Hey, everybody. Welcome to May's Masterclass. We got a good masterclass this month, one that I've special interest in just because I have gone through the whole MDT certification and credentialing process, and it is a big part of my practice. So I've gotten to know Vince a little bit just through meeting him through professional interactions. Finally got to meet him in person out in Chicago for APTA Next, I believe it was last year. So it was good to finally meet him in person. But very impressed with Vince's activities on social media, always pushing good discussions and always kind of really trying to push the needle forward in our profession. A big part of his practice, I know, is repeated motions and repeated movements. So he'll be a good ear to, or a good person to really lend his expertise this month and give you guys some good clinical tips and things you can do to start up the practice. I do think it's something that doesn't need to be cordoned off, and it's things I think we can apply. I do know, and I may touch upon the credentialing piece and some of the evidence around that, but I'm looking forward to his talk this month. But for those of you guys who maybe just joined before we just talked, feel free to interrupt Vince and pose questions as you see fit, and then we'll have a discussion at the end for our Q&A with Vince. If you want to wait till then, that's fine too. If you're not feeling like you want to throw questions out there verbally, you can type them in and I can pose them to Vince as well. We're cool either way. So with all that said, Vince, thank you for joining us, and appreciate you coming and look forward to hearing you talk.
Awesome. So thanks for having me first. I don't know if you guys have already heard it, but you may hear kids screaming in the background every once in a while. So I'm just going to throw that out there right now. Both of us are good. The kids are out playing. So a little bit about me. If it pops up, there we go. About me, I had my master's. I went on and got a transitional. I got certified in MDT in 2010. I own my own practice, but it's kind of a different ownership model. I essentially call myself more of a gun for hire. And so I work with physicians' practices and I triage their patients for them. It's mostly an HMO model, so we don't do a lot of fee for service. So really it's about how fast can we get these patients better, and if I can't help these patients quickly, how fast can we figure out how to refer these patients out to who's going to be next in line to help these patients. And so this really does come down to that pay for performance type environment. I love it, and repeated motions really works well in this environment. To give you an example of how I got there, the course that I went, I worked at a hospital program, where I worked at a small community hospital, and I started a spine care program with the physiatrists and the spine surgeons. They absolutely loved what was happening because their patients, the patients that needed surgery, we were getting them to surgery relatively quickly, and we were keeping the patients who didn't need surgery from having surgery, so the surgeons' outcomes actually improved. From there, we decided to try this back thing in the emergency department because it was the #1 reason why people were coming to the ER. And out of the 2 years that I did emergency department physical therapy, I didn't see any sinister diagnoses. I'll touch on that a little bit later in the presentation. I didn't see any sinister diagnoses, but we were keeping people from being admitted to the hospital, which was saving healthcare dollars on a whole. And so, this goes beyond just, can we help the patient in the clinic? This is actually shown to help save healthcare dollars downstream. There's a recent study that came out, sorry, I don't even think I put it in here or not. Mark Miller out of JMMT talked about a 52% downstream cost when the therapist is trained in doing mechanical evaluations. And so it's really prudent to understand how to perform these, specifically on your, the things that you're going to be seeing in the clinic: backs, necks, shoulders, hips, knees. It's important to understand how to use this because it's an easy tool to use once you understand the basic principles. The objectives, I'm going to blow through those, so we'll touch on all of these during the presentation. So we're going to start off with centralization, because centralization is the hallmark when you're looking at lumbar spines, right? And the first thing is we have to define centralization. And centralization was first described by McKenzie in roughly 1958. But we didn't see it pop up in the clinical practice guidelines until the low back guideline in 2012 in JOSPT. That's where we started seeing centralization and directional preference. So put that into perspective, right? Because that blows my mind. 1958, 2012. They talk about it takes a PT 17 years to put the evidence into practice, but it took the evidence, half a century to catch up with what was happening in the clinic. And there have been a ton of studies now, and like I said, you're seeing it in the JOSPT lumbar guidelines. We have to make sure that we're defining centralization. And in the clinic, I personally use the strictest definition that you're going to find on centralization, and that's the definition from Mark Wernicke. Wernicke says that the symptom actually has to leave the most distal segment and move to a more proximal segment. The classic definition is the symptoms just reduce in a distal segment while they're moving up towards the spine. I don't personally like using that symptom reduction model because I have bias, right? And I'm trying my best to reduce that bias. And so it really becomes binary. The symptom is either there or it's gone. And if it's gone, awesome, something is changing in the right direction. If they think it's better, then I'll just keep going with it until they tell me it's staying the same or it's gone, right? I'm really looking for that symptom to leave the segment and move up. Otherwise, I might become too biased in my treatment patterns, and I'm trying to avoid that as much as I can, because I might just hang out trying to treat something that's not amenable to treatment, right? Peripheralization. And so we also have to understand that peripheralization and centralization are prognostic factors. Okay, so peripheralization is the exact opposite of centralization, and it means that the symptoms have now gone from a more central location and they've moved to a distal segment. So, for example, it's not uncommon for you to see that patient come in who says, I have, pain in the outer border of my foot, I have numbness in my big toe. We're literally trying to turn off those symptoms and move them up either into their calf or into their thigh or into their back, ideally. But if you see the opposite happen, and this does happen, and it happens kind of frequently, and so you have to ask the questions. If they come in with back pain, you have to ask if that pain is moving at all, because it's not uncommon for you to go from back pain down to mid-thigh pain during some of the movements that you're doing in the clinic. And that's your red light, that's your stop light, that's your stop to switch directions and try to get away from that peripheralization. The peripheralization can lead to poor outcomes. I'm going to touch on that in a second. Centralization phenomenon, again, it's called the phenomenon because we don't know exactly what's happening when these symptoms are moving. We don't know physically, anatomically inside the body what's going on, right? Could it be the disc? Sure, I touch on that. Could it be neurogenic? Sure. Could it be patient belief? Sure. Could we be feeding them the answer? Sure. There's a lot of possibilities to what's happening with centralization, but nobody knows, and that's why it's called the centralization phenomenon. But we do know some other stuff, right? That if patients peripheralize or patients are non-centralizers, they're 6 times more likely to require invasive intervention. And so you have to pay attention to that peripheralization, and it's not a bad thing, right? It's not I'm failing. It's never about me. It's got to be about the patient, right? Because if a patient is peripheralizing, and I can't get them to change their symptoms at all, that's our cue that we need to move that patient onto somebody who can help them. And that's fine. There's a study out there. I don't know if I included it in this room. I don't think I do. There's a study out there by Von Tulder who covers epidural steroid injections. And if the patient is initially a non-responder, and then they come back after an epidural steroid injection, roughly 43% of the time, they become a responder. And so to me, it's just data, right? It's the symptoms move, the symptoms don't move. There is no pass-fail, there is no win-loss, there's nothing personal. And so you have to make sure that you're just looking at this from a data perspective. All right, centralization is shown to highly correlate with a discogenic lesion. That's fun for me because that brings in the disc, and a lot of people start to say, well, it's not about the disc. It can't be about the disc. Well, it's not all about the disc, but we also can't deny that there is some discogenic features that take place with centralization. Let me run through my notes section here and just make sure that I didn't miss anything on this slide. Yeah, that's Laszlo is actually the person who did a lot of the research on the disc, which I'm going to cover next, for centralization and peripheralization. So discogenic, who says that anymore, right? But 91% of your centralizers have an intact annulus, right? 25% of those that peripheralize only, right, of the 54% did not have an intact annulus. So if there's something about having an intact annulus that helps with centralization or allows for centralization. There's research out there that on sequestrations and extrusions, and this pops up all the time. I actually like this research study. It's a smaller study. I think it's an N of 14 or 15. It's a really small study. But when you see the percentages, and it just happens to work out clinically, is what I see, and maybe I'm biased towards seeing that. But patients that have all leg pain and no back pain, I don't tend to do very well with those patients, right? And so far, when I send those patients back, we tend to see that extrusion or sequestration. And I go so far, I don't know how you guys write your assessments, but I go so far as to start talking about this in my assessment of the patient, in my evaluation. Because if this is gonna be a patient that I want out of the clinic to get imaging relatively quickly, I have to make sure that I'm putting the evidence in there for the insurance company, because otherwise they're going to tell me I need to see this patient for 6 weeks. And the last thing I want is to put a patient through pain or unneeded treatment if I'm not going to help them, right? And so I'll actually refer these patients back to get imaging. And like I said, I work with a physician practice. And so if there's an imaging that I feel we need, we get the imaging. I just have to validate why I want it in my assessment. All right. Some of the other things that you see is when you do a press up, there's a water content change from the disc, and that water content change tends to reduce pain. And the other thing is we try not to use the disc model, right? And so I'm talking about the disc, and very rarely do I actually use the disc model, because we don't know what's happening all of the time. And so I don't want to say to the patient that when you bend forward, your disc goes backwards. You know, I got a link in here to that model that when you squeeze the front of the model, the disc pops out the back. We don't want to say that, because there's actually research to contradict that, right? I think it was Zhao in 2002 or 2012. I don't remember what year it was anymore. But when you have grade 3 and grade 4 disc degeneration and you bend forward, the disc actually translates forward. It doesn't translate backwards. And so we can't just use that jelly donut theory, the spine model, the bar of soap that Rob and Mackenzie like to use, because it doesn't work that way. And that's one of the reasons why I try to avoid using the disc model, is because the answer is I don't know, right? I mean, and if the patient is hell-bent on saying they have a disc issue, all right, I'll start talking a little bit more about the disc, but I tend to talk more about spontaneous resorption of the disc, right? Over the course of 6 months, we tend to see spontaneous resorption. When you move, it moves. That's how it gets its nutrients. And so I start talking more about the positives of the disc and not harp on the negatives. I don't tend to use the research out there on asymptomatic people, just because, I've had a few patients give me some backlash on that. And, the last thing that I want is, I don't want to invalidate their symptoms, right? And so I don't tend to use that research as much as I go towards an encouraging mindset and making sure that the patient is educated in a positive fashion instead of harping on the negatives that are happening with the disc herniation. Okay, so profile of responders. I'm going to touch on the Mackenzie method here for a second. By no means is this a Mackenzie method lecture. I believe, I'll give you my history real quick. While I was a student, I participated in a Mackenzie study group with some of the who's of the Mackenzie method, some of the teachers that are of the method now. And I got to practice the manual techniques and learn the theories. And it's great. And I highly recommend everybody at least go there and learn that stuff, because the research in the book is legit. The stuff that they teach on the course, I'm not going to talk so much about that, but the research in the book is legit. And I highly recommend reading the textbooks. But the Mackenzie method has 3 syndromes, right? Derangement, dysfunction, and postural. Okay, we don't tend to talk about postural, as you'll see in this slide here. The prevalence rate is less than 1%. I've seen one postural syndrome patient in my entire career, and I screwed up. I royally screwed up because I was so shocked that I was seeing it. I didn't understand why the patient actually came into the clinic, because the treatment was just get out of that position. And the pain went away and we couldn't reproduce the pain again in the clinic. And so my mind was blown, like, why would this guy spend his money to come see me? Obviously, I was a new grad at the time, and I would do things a little bit differently now in terms of educating the patient and follow-ups. But yeah, I lost the patient, right? And that was on me. That was my fault, and that's part of learning. Dysfunction syndromes, I'm going to describe those as slow changing, right? And that's 6% prevalence rate, okay? Derangements, this is the big one. This is what this entire presentation is about, right? It's fast changing symptoms. And so I'm not going to tend to call it a derangement. I'm going to call it fast changing, because that's what I'm looking for when I'm in the clinic. And when these patients come in, roughly 81% of your patients can be classified as fast changing. Now, fast changing could be bad, right? I could peripheralize all these patients. That's still fast changing, and it would still fall into that category, but they wouldn't improve typically, right? And so 6% of the patients tend to fall into that irreducible or not lasting improvement in this fast changing group, right? And so I keep things very simple when I'm in the clinic. Anytime that you do something with the patient, only 3 possibilities exist. They can be better, they can be worse, or there can be no change. And that's what you're looking for. If the patient is better or worse, after you guys perform your movements, you have something fast changing, right? You have to define better or worse. You know, you have the numeric pain rating scale is like, 30%, 2.2. I don't go there at all with patients. It's very simple. Are you better, worse, or the same? I think I'm better. All right, let's do more. Let's see what happens, right? If they tell me I think it might be, then I chalk that up to no change. At some point, I'm going to ask them, all right, we've done 80 repetitions of this now. Would you say, wow, I'm better? And if I don't get a wow, I'm better, I'm done. I'm looking for that wow moment in the clinic. And I'm really looking to create that change in the clinic in front of me, because not only would I like to get the patient better, but at some point in time, you've also got to establish therapeutic alliance, right? And if I never get that wow moment, they may never come back. And I know I can't help the patient that never comes back. Even if we create a wow moment in the opposite direction, that at least gives me something to sell the patient. Well, if we can make you better, then there should be some sort of opening for me to make you, or if we can make you worse, there should be an opening for me to make you better. And so we're going to explore some other directions that we might do that on visit 2. But that fast changing is what you're looking for. The dysfunction patients, I tend to give those graded exposure over the course of time and do a lot of education. We rarely see those patients in the clinic, maybe once every week, every other week in the clinic. But for the fast changing patients, you're really trying to create that change now. Now, again, there are some patients, you'll see 13% of them that you can't classify. That sucks, right? That's why you can't depend on one type of method as being your only method for treating patients. Because 13% is, it's still 1 out of every 10. 1 out of every 10 patients walking through your door, you can't use this for. And that's not fun to feel like you're banging your head against the wall. So clinically, I tend to use the pain mechanism classification system in conjunction with the McKenzie method. One of the, I get into this discussion frequently about the treatment-based classification system, because it's the system that's taught in schools. I take the students, and I keep hearing treatment-based classification system. There was a study done by Stanton in, we'll say 2012. I don't know why I like 2012. But there was a study done by Stanton, and one of the problems that I had, and I actually had discourse with her, Tasha, on this study, was only 25% of their patients are classifiable using that model in those years. They've since upgraded it a little bit, but using that model in those years, you could only definitely classify 25% of your patients. Now, you can classify 50% of the patients into one of two groups, but you can only classify into one group 25% of your patients. That means, 75% of your patients, I'm either taking a guess or I can't classify. That to me is that's not good. That's not even better than a coin flip, right? And so that was one of the things that I had trouble with during the discussions on the treatment-based classification system. All right, moving on. Okay, so directional preference and prevalence. So in school, right, I don't know about you guys, but I got a short lecture on the McKenzie method, and I was taught all about extension because that's apparently what it is. And the reason why that's what's taught is because of the numbers. And so when you pay attention to the numbers, remember, you have roughly 70 to 80% of your patients are going to be fast changers, depending on whether you're looking at Hefford's research or May's research. 70 to 80% of your patients are going to be fast changers. Out of those 70, we'll take 80% because it's the higher number. It's easier for me to work with. Out of the 80%, 70% of them tend to be extension responders. So roughly half of the patients that walk into your clinic are extension responders for lumbar pain. That's the reason why it gets that stigma that it's only extension, but you can't deny the other movements that are out there. When you look at the prevalence rate for lateral, it's 24%. That's still a fairly big chunk of those fast changers. And I tend to go lateral very quickly, and you'll see that in the next slide what I'm talking about, but I tend to go lateral very quickly when I'm working with patients. 6% of your patients are going to be flexion responders. 6% of the 80% are going to be flexion responders. That's hilarious, right? Because I graduated in 2007. I started practicing in 2007, and flexion was like king, right? Everybody flexed. And if you read the low back guidelines from 2012 JOSPT, they talk about flexion. And the answer was, you can do it. It's based off of weak evidence, right? And that was the recommendation in the synopsis for the back pain guidelines. Yeah, you can use it, but it's not your bread and butter. It's not really going to help a lot of your patients. I might use flexion with stenotic patients. I might use flexions with patients that I can only buy them a little bit of relief, but I can't create that long-term change. There are some patients that are just definite flexion responders, and I'll give you a good example, right? One of my physicians that referred to me in the emergency department, he walked in one day and he couldn't bend over. And it was just a stiff walk. And, and I chuckle, because he thinks he's a back pain guy. He thinks he understands what's going on in the spine. And he just said I had some inflammation. So I took him through a bunch of flexion and lying, and his symptoms completely abolished. Gone. He was able to bend, and he was able to walk, and he didn't look like stiff man anymore. And then I asked him if he wanted to see something cool. And so I had him lay down on his belly and do a few press-ups. And all of the symptoms returned. He wasn't able to bend forward anymore. He was completely blocked going forward. He could only go to mid-thigh. And he walked like stiff man again. He had trouble understanding what was happening, and I honestly, I don't know. That's my answer. I don't know exactly what's happening. All I know is you got better, right? And we know the patterns that exist, but we can't explain why the patterns exist. But we know the patterns are out there. So there are flexion responders in the world, but most of the patients are going to be extension or a lateral component. Let's see what I got here. All right, yeah. So this is a patient response system. Okay. Anytime that you're looking at fast changing, slow changing, you're defining that based off of the patient's response. And for me, it's a game. It's always playing, right? I always go to work and I have fun. I get to play. And initially, when I'm evaluating patients, it's like playing craps. It's playing the odds. The odds are I'm going to land on extension, and so I'll start at extension. The next odds are I'm going to land on lateral, so I go to lateral. the final odds are for flexion. And so flexion is the last thing that I test, and you'll see that in the next slide. This is like, I drew this out because, and I catch a ton of flack for this, right? So I talk about the clock. Well, I used to talk about the clock a lot because to me, this looks like a clock face. And, 12 o'clock is flexion, 6 o'clock is extension, 3 o'clock and 9 o'clock are pure lateral. The top half of that is some version of flexion with lateral, and the bottom version of that is extension with lateral. This makes perfect sense to me. And every time that I see this, I know exactly where I'm going. I'm going 2 o'clock, I'm going 5 o'clock, I'm going 6 o'clock. I can just call out numbers, and my students actually know where they need to go, right? They memorize this table, and we start talking about what number should you start on first. And a version of this is in the McKenzie textbook. The reason why I don't like what they do in the McKenzie textbook is because I believe it's like page 163-ish. What I don't like is they call this the disc model. And they describe how the disc moves when you go through these motions. And we've already covered that that's not exact. And so I don't like talking about the disc when I do this. I only talk about the movement. And so when a patient comes in, you'll see it down here. I mean, this is handwritten, right? I just took a picture of what's in my clinic. Clinically, I always start at 6 o'clock. I always start with extension. Now, if the patient tells me that I shouldn't be going to extension, then I move, right? If the patient's symptoms peripheralize, I move. If the patient is demonstrating worse myotomal changes, I move. If there's changes in dermatomal issues that are for the worse, I move. If dural tension has worsened, I move, right? But I always start there. It's my baseline. It's where I go first in probably 90% of the cases. For those patients that I have no clue what the hell is going on after the history, I start at 12 o'clock. For patients that come to me with knee pain, I start at 12 o'clock. And I'll touch on this in a second, but there's research out there to show that if a patient has a directional preference and you give them exercises opposite of that directional preference, they tend to do worse. And actually they drop out of the study because they were that much worse, right? And so if I have absolutely no clue what's going on, and 70% of the 80% is extension, I start at flexion. Because I want to try to make the patient change, even if it's for the worse. Because it gives me a hint as to whether or not I'm looking at fast changing or slow changing. When the patient is first coming in, once we've established that the patient should be in the clinic, and again, I'll touch in a second, once we've established that the patient should be in the clinic, I need to know, are you a fast changer or a slow changer? Because that's what's going to dictate how I move you through your treatment paradigm, through the episode of care, right? And this is in my head for every joint. You notice I don't give you examples of which way to move here. I just give you what's happening joint-wise in my head, right? Extension, the joint is closing. Flexion, the joint is opening. Side gliding, one side is side gliding. I'm not sure if everybody knows side gliding. Let's talk about side gliding for a second. There's research to show that when you do side bending, lateral flexion, which is typically what's taught as the standard lumbar evaluation is lateral flexion. But when you do lateral flexion, you affect the lower thoracic segments and the upper lumbar segment. We see prevalence research to show us that 95% of lumbar symptoms correlate with L4, L5, L5, S1. But if our assessment is actually targeting lower thoracic, upper lumbar, we may never see it, right? We may never see the change. The research article shows that when you do side gliding, you actually affect the lower lumbar segments. And so that's the reason why they include side gliding in the McKenzie method and not lateral flexion. But again, if you're looking at a thoracic patient, you might choose to do lateral flexion. So anyway, side gliding. You could side glide in one direction to close. You could side glide in one direction to open. You can flexion rotation to gap, or you can flexion rotation to gap less, right? And that's kind of how I look at it. I keep it very simple. For the shoulder, you can extend, you can flex, You can lateral, horizontal abduction or adduction or rotations, right? And you can flex and extend with those motions. This is a very simple paradigm in my head, but it takes me to where I need to go with my assessment. And from there, I'm just paying attention to the patient's response. Okay. You have to be patient, right? As fast as I'm trying to go through this, because I need to figure out if this patient belongs in my clinic or if I need to refer out for imaging or, injections or surgery, you still have to be patient. Wernicke's research shows that it could take up to 7 visits in order to classify into your grouping fast or slow, right? What that research article shows is that if there's no classification by the 7th visit, your outcomes trend towards poor. And so when I go speaking to the physicians, because I sit in on these meetings weekly, specifically for the new physician, I'm saying, give me 6 visits. That's it. Give me 6 visits. And if we haven't figured out what's going on in 6 visits, I might not figure this out in 6 months. So all I want is 6 visits from you. And they don't, and I don't tell them I want 2 times a week. I don't tell them how to set that up. I just say, evaluate and treat, give me a diagnosis, tell me 6 visits, and make sure you sign it with a date. That's it. Because I want to try to figure out what's going on with this patient and where this patient needs to go. Okay, so, but again, 7 visits is my cutoff. And so I know I'm already on a timer on day 1. Right? My head is flying to try to figure out, are you a fast changer or a slow changer? And with that, we're using subjective, centralization, peripheralization, wow changes for pain. We're using mechanics. Is your range of motion changing? Are you being blocked in a motion? Is a motion opening up for you after doing something? Did your dural tension change? Are we seeing myotomal changes? Are we seeing reflex changes, dermatomal changes? All of this goes into the evaluation and the assessment. And all of this happens each session. And so it's not something that I'm doing on day 1 and I never revisit it again, because this is essentially my map quest, right? This tells me whether or not I'm traveling in the right direction or if I'm going in the wrong direction and I got to switch course. There's one article out there on, this is just, I don't know where this information fits, so I just put it here, right? There's one article on recurrence rates. And there's an article written, you got to love, the military, because they have a huge pool of people with which to experiment on, right? And so there's a large N. And the recurrence rate was 55% for people that stopped doing their directional preference exercise, but only 33% for those that continued twice a day for 15 reps. So once we establish the directional preference and we get the patient and they've gone through recovery of function to where they feel better and they're back to life, this is what I leave them with. Because it's the only article that I could ever find that tells me what to do with the patient, right? And so this is where I take comfort in research. I try my best not to guess, and this is what I tell the patient, right? We can cut your recurrence rate down if you just continue doing your exercises twice a day, 15 reps. All right, so directional preference. I didn't actually define directional preference to begin with, so let's cover that now. Directional preference was first coined by Ron Donaldson, 1991-ish. And essentially what they're saying is with direction, when you find a direction, you see positive changes in mechanics or symptoms. If you see centralization, whatever motion you saw centralization with was your directional preference. If you create a major change for the positive, whatever that motion was is your directional preference. That's your starting point. Okay, so now that we understand directional preference, we look at some of the research that's covered on it. And this is one of my favorite articles, right? Like I said, research gives me comfort. And so does it matter which exercise we give the patient? And if you follow this case series, because it's actually two articles, the answer is yes. Okay, so these patients were matched into 3 groups. We have to start off by saying the evaluation was performed by a credentialed MDT or diplomaed MDT therapist. This matters, all right? So I don't like to sell the method, but it matters, right? Because There's research, I know Herbawi, and it'll come back to me, but Herbawi was one of the authors on the study that showed the reliability of the evaluation using the McKenzie method was actually fair to poor in those that weren't at least credentialed. And so if you're not credentialed, you might not be classifying it the way that these research articles are. And that's an important take-home message, is that you give me a wrench and I'll teach you how to use it like a hammer, right? I mean, I'm not the best with tools, and if we just teach people some of the tools, they really do need a lot of practice and understanding the research behind what's going into these tools. So anyway, these people were randomized into 3 groups. They were given their matched directional preference as one group. The second group was the unmatched directional preference. It's kind of what I talked about a little bit. If I know that extension is a directional preference, I might look at flexion to see what happens, right? And so that would be the unmatched directional preference. And evidence-based practice, which was general exercise with some manual therapy. And these patients were given 6 visits over the course of 2 weeks. Here, the results are actually pretty cool. So no one from the matched group withdrew. So those that were given a directional preference, they stuck the course, right? They stuck it out and they stayed in. But 35% from the opposite group withdrew. Almost equal from the evidence-based practice group withdrew. And they withdrew, the article cited it as because of a worsening or lack of improvement, right? And this has to cause us to scratch our head a little bit, because if we believe that we're following evidence-based guidelines, but roughly a third of our patients are actually not getting better, are we following the right guidelines? And these are just internal questions that I ask myself as I'm reading through research and trying to understand what we're doing, because it's constantly a learning process. And so, you know, when I first started, it was manual therapy and exercise, right? And because there's a couple of research articles out there that show patients do better with manual therapy and exercise. And this is just, and if you look at the method, it's just a different version of manual therapy and exercise. And so it's hard to compare it against other manual therapy exercise research. Anyway, tangent. So the results. Every variable measured favored the matched directional preference treatment group. So the take home from this was matching the directional preference seemed to give us improved outcomes, right? 90% of patients reported improved or resolved symptoms. And a good prognosis, good prognosis can be negated with the wrong exercise. Oh yeah, okay, here's what I was saying. You can have a patient who has a directional preference, and we can still screw it up. So if I have a patient who walks in the history and says, you know, I get worse when I sit, I get worse when I bend, but gosh darn it, if I bend backwards, I feel good. And if I give them a bunch of bending forward stuff, I can screw the whole thing up, because they'll drop out, right? And they don't come back. And I already said I can't help the patient that never comes back. So we're trying to listen to the patient in the history section to get the information that we need to understand where we go with our treatment. Let me just make sure that I'm not missing anything here. Oh yeah, there's a few people out there in the internet world that have the saying, you can't go wrong getting strong, right? And this research to me kind of contradicts that, because if I just give them general strengthening exercises, they might still get worse. Right. One of the ways that I look at directional preference, there's another person out there, I'm not sure if it was Greg or who says it, but calm stuff down, build stuff up, right? And that's how I look at directional preference. Directional preference is just a way to calm stuff down, and it allows me later to build stuff back up again. And so, you know, this isn't a magic trick, right? It's give the patient what helps them to improve, so that way we can start getting this patient back to life. Okay, so the second study in this case series, this was fun, right? And like I said, research gives me comfort. So the Audrey took the patients that withdrew from the first research study and said, well, let's take those patients and see if we give them the directional preference again, what happens? And surprise, 84% of patients that we initially made worse are now either improved or completely resolved after 2 weeks. So I'll tell you what this means to me. This means I can screw up for 2 weeks and still come back and get a positive outcome, right? And so this article series made me a little bit more fearless in the clinic, because before I was really worried about making a patient worse. I was worried about increasing their pain. But knowing that I can screw up or increase their pain, screw up in the patient's eyes, knowing that I could screw up, I could still flip the course and get a good outcome, right? And so a patient can be made worse from the wrong exercises, but this worsening can be changed if the patient is issued the exercise that correlates with their directional preference, right? And so now I have no fear of moving them in any direction. I don't care what the direction is, because I want to see what the response is going to be, because this is like a chess game. The response can only be better, same, worse, and my next move can only happen after I understand what their response is. So this is where it becomes fun for me. It's now a game. And that's exactly where I was going. The patient's response is like a chess game. So this same, better, worse paradigm is used throughout the entire course of care. And I'm not just looking at symptoms, right? Again, you have to go back to your objective measurements that you took to determine whether or not the patient is actually better, or if I think the patient is telling me that they're better, right? And again, I'm trying to remove my bias as much as possible. And so a patient's angular change on their straight leg raise, that's a change, right? You know, if the patient is able to dorsiflex, that's a change, you know? And so I'm looking for those objective changes, so it's less me trying to gauge, was this an actual change, right? Let me see here. Yeah, again, I'm looking for the wow change. That wow is going to be the only thing that the patient can tell me that will keep me going down that track. If the patient is giving me, it's a little better, it might be better, then I can't use that, right? It has to be a wow change. Getting back to the beginning of this, right? I had mentioned that there are fast responders and slow responders, right? You still have to do this for your slow responders, because if at any point in time, who I thought was a slow responder is now worse, meaning they are wow worse, or I have greatly changed one of the objective measures, I got to go back and figure out, did I do something wrong? Because this patient just rapidly changed for the worse in front of me. And who I thought was a slow changer is actually a fast changer. And so now I have to restart my assessment all over again to see, did I even get the slow fast classification correct? And don't be afraid of doing that, right? Patients appreciate that. And the reason is that, you know, your slow changes, right? When we start looking at let's just look at muscle strength, right? 6 weeks, right, is when you see these maximal gains. And I don't want to waste 6 weeks on somebody who's a slow changer if they are actually a fast changer, right? And so I want to make sure that I waste only 1 or 2 days instead of wasting 4 to 6 weeks of their treatment, and I completely miss the classification. That's the patient's paying money, they're taking their time. I want to make sure that I've done my best and done my due diligence to classify this patient correctly. And when I start talking about better, worse specifically, I'll use the standards from A World of Hurt textbook. I highly recommend that book. Good friends with Andy O'Connor, but I highly recommend the book. And again, it's no lasting increase in symptoms, and you know, the patient's not functionally worse. Let's see if I got anything else here. You still use you still use repeated motions for slow changers. You just use them a little differently, right? So like when you look at your slow changers tend to be what are frequently called tissue-based changers, right? So like your muscle strains, your capsulitises, you're still using repeated motion, but you're doing more of a graded response over the course of that repeated motion. So it's still used for slow responders, but I'm really looking to see if that slow responder was misclassified and should be a fast responder. Obviously, assess for red flags when you're looking at your lumbar patients. You know, I tend to assess for single leg stance for low back pain. I tend to assess hip abductor and external rotation strength. There's a lot of research out there to talk about single leg stance times with low back pain. and it being impaired. Interestingly, it's typically impaired on the side that's asymptomatic, which I think is kind of cool. But I can't explain it, but all I know is that it's there, right? The research is there, it comforts me, so I test it. And it's something that we try to recover back to a better ratio as we're getting that patient back to function. And there's research on hip abductor weakness and external rotation strength weakness being significant factors for developing back pain. And so I address those after we've covered that directional preference. The patient is well better. We've reduced their objective measures, and now this is part of the return to function that I go through. But again, you have to assess to see what's going on with the patient. And so down here, I evaluated a grandmother once, right? And she came in. She didn't bias me at all, right? They didn't want to bias me, which is actually pretty cool coming from the patient's perspective. And I took the history and, all right, yeah, well, you might respond to movement, you might not. But every direction that I moved this patient in, she peripheralized all the way down her leg. And there wasn't a single direction that I could figure out as to centralize her symptoms from her the plantar surface of the foot up the leg at all. And so on day one, I'm already starting to prep the patient that I might not be the answer or have the answer for the patient, because I'm okay with selling something if I know we're going to make good progress. But the last thing that I want is to set unrealistic expectations for the patient. And so I don't want this patient coming out of day one completely believing that they're going to get better if I don't have that same belief, right? And so I started the conversation that I didn't think this patient was going to improve, and her daughter said, well, she's already gotten 3 different surgical evaluations, and she's a prime candidate for surgery. And so I saw the MRI, and the MRI literally looked like a game of Jenga, right? like things were out of place so far that I thought they were going to slip, and the whole tower was going to fall. And so, I wasn't afraid to move her. And interestingly enough, I might have been afraid had I had seen that MRI initially. But this is where we take the research for centralization and peripheralization, right? We have that stopgap already built in. We know that peripheralizers do worse. Don't push them to peripheralization, right? Don't make the patient worse. And so, needless to say, that patient has come back to me for other episodes of care for different areas, and I've seen the entire family, right? And that was because I was honest from the start. And I didn't establish unrealistic expectations, but we do know that we have to make sure that we're establishing expectations in that therapeutic alliance when we're treating patients. Oh. I don't know, I just took your poll. All right. There is a case presentation that makes me a little nervous. I have a case series that I wrote up as part of my doctorate program. It was a retrospective case series. And I've had 4 patients in my career that came to me, and I was the first one to suspect cancer. Out of those 4, 50% died relatively quickly. And so this presentation scares me a little bit. And as I was writing up the case report, it's not the first time the presentation has been seen. It's actually already out there in the research. And it's when a patient gets temporary relief with maximal gapping technique, that flexion, rotation, unloaded, and they say, I feel better, the symptoms are out of my leg. But as soon as they come out of that position, the symptoms all return back down the leg. Now, in the cases that I wrote, remember, I said I'm very honest in my assessment, right? I tell you exactly what I think is going on. And in these cases, I wrote that I would like an MRI to assess for a space occupying lesion. I don't know what the lesion is, but I know that when I give this patient max opening, they feel better. And there's a Bill Boisenau talks about in one of his studies that when you put pressure on, he called a diseased tissue, you create a nociceptive response, and you can elicit pain. And so my thought was, well, I must just be taking pressure off of some sort of diseased tissue, and I don't know what that tissue is, so let's get an image and see what's going on. Yeah, the one patient showed up on day one with peripheralization, and it was a cervical patient, and I had absolutely no clue what was going on because I can only max open to reduce the symptoms. And so I called this physician. Again, you've got to make sure that you're establishing relationships with these professionals so you can have these conversations. And so I called this physician and said, "Hey, doc, I don't know what the hell I'm looking at. I have no clue what's going on because I've never seen this before." And he said, "Is the patient still in your clinic?" Yeah, he's right in front of me. "Call 911. Tell him I'll meet him at the hospital." Okay. Totally taken aback. The patient died the next week. He had a large tumor in the cervical spine and died as a result of surgery. Right. This presentation I have seen enough times that it scares me when I see it, and I have conversations with physicians as the patient is walking out the door. I am going to find a number. My next patient can wait because this presentation scares me a little. None of the patients that I saw that had cancer, that were later diagnosed with cancer, had weight loss. So, even though it's a red flag out there, none of them are it. There are some things that you need to know clinically, right? Because again, I dove into this after I saw these patients. If a patient has a history of cancer and they come to you with back pain, we don't get to interpret blood work, right? That's not what we do. But we should know that the next step is an ESA, right? Or an ESR, sorry, is an ESR testing, because the primary care physicians might not know that. But that is the next step in the algorithm for patients that come with a history of cancer with low back pain. And it's extremely important that we're doing that, because these patients all had elevated ESRs as I went back and looked at their cases. And it's an ESR over 50 triggers the next part of the algorithm, right? And so we don't have to know the whole algorithm, but we need to pay attention to step one. And that's what I write in my assessment, that this patient may benefit from an ESR for blood work. So yeah, just pay attention to these. They're not often, like I said, 4 and 13 years, but obviously they're there. None of those patients were from the emergency department, which was surprising. Okay, so my clinic, when you start using directional preference, you start creating changes, right? And so it's me and another PT, and the other PT actually studied under me, volunteered with me for almost 4 years before I hired him on as a therapist, right? And there's still a change or difference in how we practice based off of our practice patterns. And so one of the things that, if you are going to add this into your practice and you don't own the company, it becomes a conversation that will come up, right? I've been pulled aside in different businesses that I didn't own because I wasn't treating enough, I guess is the best way to say it, right? And so my average is 9 visits over the course of 12 weeks. The other PT averages 14 visits over the course of 12 weeks. In a fee-for-service environment, you're losing that clinic is losing money by not meeting what they think their average is. And so these are conversations that will happen. I have these conversations with my students because they see it in the clinics. And so, this is just life, and I want to make sure that I'm not, feeding you guys, rainbows and unicorns, and then you end up having these conversations and, you don't like me. That's not where I want to go. Right. And so the other therapist, if we were in a fee-for-service practice, he would generate about an extra $340 per episode of care. Right. And like I said, when you start using this, you reduce downstream costs. And so if you're in a practice that cares about downstream costs, that's important. If you're in a hospital system, right, where they are the home base, then that's important. Right. I'm in a physician group where we are the home base. We get the payment, and then we have to dole out payments, right, from there. So that's important to us to be able to reduce downstream costs. Spend a ton of time on spine, right? So now we're going to go to extremities. So there's research out there to show that in the extremities, the derangements still make up a large percentage. Even when you're looking at an extremity, a shoulder, a knee, a hip, a foot, whatever, roughly 45% of those are still spine related. So almost a coin flip is still coming from the spine. I don't know how many of you are active on social media, but I hear the lip service, screen the spine. Make sure you screen the spine. And when my students come to me for screening the spine, they just look at range of motion. Oh, range of motion look good. Let's move on. And they want to move on to the shoulder because that's where the problem's at. And so they want to move on to the shoulder. Make sure you rule out the spine first, and you rule out the spine. I rule out the spine with repeated motions. And like I said, if I don't know what the hell's going on, I go flexion first. But if there's something in their presentation, whether it's their pain pattern, whether it's their history, something in the history tells me that the spine might be there, I go the same thing, 6 o'clock, 2 o'clock, 5 o'clock, 12 o'clock, right? I don't change that pattern, and I might spend some time hanging out at the spine. I might spend 1 to 2 days on the spine before I go to the patient's main complaint. Now, if I create a change within the first day or so, the patient's happy, right? Because we found something that might actually help them get better faster. But if we don't find something in the spine, I got to make sure that I'm moving away from the spine because that patient came to me with a shoulder problem, right? I got to make sure that I'm at least addressing the shoulder or the elbow or the wrist or something, because I don't want to lose that patient. I can't help the patient that doesn't come back. And so I have to make sure that I understand the patient's expectations. They have a shoulder problem. So I have to get back to that. And even those that have an extremity problem, 43% of them are derangements, or like we said before, fast changing. And so you still assess them with the repeated motion exam, flexion, extension, laterals, and combinations. And so when you start getting into extremities, again, 1958, 2012, right? That's how long it took for this to actually strengthen in the research. When you start getting into extremities, this is relatively new. You're going to find case studies, but you're not going to find, random controlled trials. You're definitely not finding systematic reviews. So you're reading a lot of case studies and you're looking at their pictures to try to figure out what they did to that patient in the article, right? And so for the shoulder, you're going to have shoulder extension, flexion, laterals, combinations, right? Now, for me, I'm looking at a rapid resolution, and I'm looking at objective measures, right? I'm looking at range of motion. I might be looking at strength. I might be looking at hand dynamometry. And so I'm looking at a few things to see, am I actually creating changes to this patient, right? And again, I don't want to waste too much time on the spine, but I also don't want to waste 6 weeks on the shoulder if it's a spine. So again, there's some videos that are out there. I gave you guys links to the videos. I was trying to find my video. I do have one that's a rapid change in a shoulder. I'll give you the real quick rundown. Patient comes in, MRI, adhesive capsulitis, bursitis, complete rotator cuff, full thickness tear, and she's preparing for surgery. And day one, patient, she gets to about 80 degrees, right? And Mark, if I find the videos, I'll send you the link to the videos. They're on YouTube somewhere. 2 minutes later, same patient, same dress, same treatment area, full range of motion, completely restored, pain-free. And all we did was extension with adduction. We changed it a little bit because I kept getting better, but I couldn't completely resolve her symptoms. And so we added speed, right? I had her literally throw her hand behind her back into extension and adduction. Looked a little weird, right? But her symptoms completely abolished after that. And so for me, I don't get to judge the exercise. I only get to judge the result. And her result was a great result. So I'm going to say it was a good choice to go with that exercise. But you have to remember that little circle that I drew, it's important enough that it's tacked up in the offices of the clinics that I run, because I want to make sure that all my therapists understand the basics before they start delving off into stuff that may be a little bit more complicated with the patient. All right, so the pattern that I use for the shoulder, and again, you guys got a video about Scott Herbawi covering, common patterns. If the patient has pain with flexion or overhead motions, I have them start off with extension, right? This goes back to that circle, right? Nothing changed. If the patient is better with extension, then flexion is typically an aggravating force. If the patient is worse with flexion, then I start with extension, right? I mean, just pick the opposite direction. And then from there, there's some research in JOSPT to talk about the hand behind back movement. And then I'll look at horizontal adduction with and then combinations, external and internal rotation, kind of like the sleeper stretch, right? The sleeper stretch is a combination stretch. Patients that have pain with extension or reaching behind the back, we'll typically start off with lateral for them because that's the pattern that I tend to land on the most. So now I just start there. Hip patterns. If the patient presents with buttock, groin, or thigh symptoms, that's a high percentage of a hip joint referral, right? Less likely if it's below the knee, but it could still happen. It's just less likely. So that's why you have to screen the spine, right? You always got to make sure that you go back to the spine. There's not much out there for the hip right now, even in terms of case studies, but nothing changed. The hip is the shoulder, right? That's what I see. The hip is the shoulder. And so you have flexion, extension, adduction, abduction, rotations. So, and then you can combine those. You're looking at, I'll give you a quick case study, right? One of the physicians that I work with, he had hip impingement diagnosed on MRI, cam deformity. Couldn't squat, just couldn't squat, and had to do sissy squats. I don't know if you know what a sissy squat is, but it's a bend at the knee. So he was doing sissy squats to try to make up for that. And he came to me looking for a hip abductor strengthening protocol, right? Because if you look at the protocols out there for these cam deformities and labral tears, that's what's given, right? It's a lot of hip abduction strength. But so I put him through an evaluation like this, and after performing hip extension with slight abduction and internal rotation, he was able to perform a full squat without any pain. And I can't explain what's happening in there. There's some people that are trying to explain it based off of the research from Susan Mercer. Susan Mercer, I believe she's out of Australia. What they're finding are these fat pads that are within the joint, and these fat pads can move in and out, like they're actually referring to them as like a meniscoid fat pad. And so they can move in and out almost like what we see in the disc in the spine. And so, it's just fun to read, but, we can't hang our hat on it because it's theory. But it's fun to read. The knee. So I don't know if I said it yet, but rule out the spine. So 44% of patients that come in with knee pain had a spinal classification in this research study. Speed kills. I'm trying to find this out as fast as I can. And roughly 80% of the patients can be classified by visit 4. And classification in this research article was the only variable predictive of the outcome. And so that's important for me, right? I'm looking at directional preferences. And when you look at the Rosedale study, which is, I think I cite in here a little bit later, when you look at the Rosedale study, patients that have severe osteoarthritis of the knee, patients that are set up for knee replacements can improve. You can give them directional preference exercises and they improve. Some of those patients still chose to have surgery. That's fine. But they demonstrated significant improvements in their outcomes. And that's important, right? Our goal is to figure out if we can change the patient. Well, I'm not going to keep everybody from surgery if that's what they have their headset on, but can we give them value and can we start to give them part of their life back, right? And so with the knee, I tend to go extension. Okay, so here, this is the Rosedale study. There are other research studies out there that you can actually change your special tests. I don't tend to use them too much. I don't know if you guys know Jeremy Lewis, but I tend to fall in line with Jeremy's thinking, where these special tests really are just pain provocation tests. And I'm using that as a baseline measurement for which to go back and see, can I change that? And frequently you can, right? You can turn these McMurrays from positive to negative. On the shoulder, it's very frequent that you turn an empty can from positive to negative, a painful arc from positive to negative. So, you go back and you're using these tests not to tell you what the problem is at the tissue, but more to give you a baseline from which to go measure. And especially for patients who they can't tell you what causes their pain, right? If they don't have a baseline that I can go back and test in the clinic relatively quickly, then I'll move to a special test to try to figure out, can I cause you pain now? Because then I can figure out if I can change your pain now, right? And so for the knee, you have sagittals, rotationals, and combinations, right? So you have your, the 7 to 10 degree rotation, and you have extension and flexion, right? And you can combine those. And what we tend to see is extension, right? And one of the reasons why the McKenzie method gets hammered with extension is because when you look at it, it tends to fall extension, 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 right? Knee extension, hip extension, elbow extension, wrist extension, right? They fall extension, 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 extension. But if that's what the patient responds to, that's what the patient responds to, right? And so I cut it off at the knee here because when we start delving into the elbow and the wrist and the ankle, you're really only finding research articles from Joe Macchio of Macchio Physical Therapy out there in New York. Great guy. You know, when he first graduated, he was a travel therapist. He came to our study group here in Chicago. But he's the one right now who's kind of leading the charge with putting out the case studies. And there's some videos that you can see in the link that I gave you guys. But you know, nothing changes, right? It's that circle, flexion, extension, lateral combinations. So whether you're looking at an elbow, whether you're looking at a wrist, whether you're looking at an ankle, a great toe. Gosh, I had a patient come in with turf toe. We did a bunch of repeated flexion of the great toe and the symptoms abolished immediately. So it's not hard, but you have to test it. And you do have to spend some time on it in order to determine whether or not you're getting the results that you're looking for. And if you're not, remember, there's 13% of patients that are unclassifiable. You move on. Okay. I think that's the end. All the research articles are here. There's some other resources in here that, you know, they're fun to look at. I didn't include them in the study, but they're fun. All right. Any questions?